All right, look at me cooking with gas now. I feel like a true IT professional now. I don't think I am, but you know what I am. So again, I want to apologize for everyone for being a tad bit late. So I'm gonna jump right in to introduce you to some of our great guests. I'm gonna start with Dr. Christine Teague. Dr. Teague, do you want to tell the people who you are, what you do, and how you ended up on this crazy call?
Sure. Hey, everybody. My name is Christine Teague. I'm the director of the CMC Ron White program at Charleston Area Medical Center in Charleston. We're one of two federally funded HRSA grantee programs, Part C program, in the state of West Virginia, and we get funding for primary medical and support services for individuals living with HIV in 19 counties in the southern part of the state. So Kanawha County, where I'm located, obviously we have our main clinic here, and then we have patients that come from all over the southern part of the state to clinic either here at CMC, or more recently we opened a new office in Beckley, an hour south in Raleigh County. And I've gotten to know Tony over the last year or so, with given her work pursuing positive outcomes in the HIV Hep C SUD syndemic issue here in West Virginia. I'm glad to be here. Thank you.
Perfect. Thank you so very much. Laura Jones, are you here somewhere?
Laura wasn't going to be able to make it today.
Okay, perfect. Thanks. And then we've got Angie Settle. Come on, it's 2021 now. You gotta, to hit the mute button.
I know, you're right. Always have to turn it muted, make sure you don't hear all this stuff going on. Dr. Angie Settle, CEO, West Virginia Health Right, a doctoral prepared, board certified family nurse practitioner. Been with West Virginia Health Right, which is the state's oldest and largest free and charitable clinic since '97. Our finger in a lot of different things as far as primary care and everything else, but working with Tony a lot on the HIV issue on the west side. We've been doing a lot there. I've got all the numbers here. Put about 60 people on PrEP, I believe, in the last. Rhonda's my numbers person, so she keeps me on the straight and narrow, but we have a big list of all the things and the outreaches that we've done, but trying to do a lot with underserved, homeless, shelter population, COVID, flu vaccines, and all that.
Rhonda says she tries to keep you honest, but that's the hard part. Yeah. I'm not naming any name. I'm not naming any names or doing any things or saying any things about you. Because
Tony, you're supposed to have my back now.
And listen, I just tell the truth. I can't do this without just telling the truth. And then next, she was just right there on my screen, and now she moved. Suzanne, oh, there you are.
Suzanne is still in another meeting. She's loaded in on this meeting, so she can jump over as soon as it's done.
Okay, cool beans. So what we will do then is go ahead and start talking about, so Dr. Teague, one of the things that you're famous or infamous for is your kind of mobile testing, particularly around people with lived experience with HIV, but also many people don't know kind of like what the Ryan White program is and don't know kind of what you do in community. Can you give us a bit of an overview of what CAMC is actually doing with people with lived experience, mobile and portable services, and why those are important in West Virginia?
Sure. Well, that's a lot. Hopefully I won't drone on and on too much. But our mission is to provide comprehensive outpatient primary medical care to individuals with HIV, but also outreach and testing and linkage of people who would be at high risk for HIV. And so a large majority of what we do is actually take care of the people that are known to be HIV positive. And as I said before, we do that either in our clinic setting here at CMC on the Memorial campus in the outpatient care center, or in the office in our new location off of Harper Road in Beckley. We have about 425 individuals that are enrolled in our program, about half of them live in Kanawha County and the other half come from all over. And prior to about 2018, 2019, the majority of people that we took care of were primarily had acquired their infection through sexual transmission. So a lot of sexual and gender minorities we saw in the program who had many, a lot of issues, particularly stigma-related issues, and limited income. But for the most part, these were people that were housed and some semblance of income. Then everything kind of turned on its ugly head in 2019, 2020, when the epidemic shifted into largely an injecting drug use community. And when COVID hit last year and people were hunkered down, we really didn't see much at all in terms of new cases of people who were acquiring HIV through sex. It was all people who were sharing injection and equipment to inject their drugs. And as you know, we have a cluster now that's around 85 individuals. And I would say right now we're trying to engage and link into care about 60 or 65 of those people. We have had some deaths, and we have had some individuals that have relocated to other parts of the state and outside of the state. But it's an ongoing intensive effort, and a lot of those individuals do come from the west side of Charleston, where West Virginia Health Right does have a dedicated presence now, which is wonderful in terms of a clinic over there and also outreach testing. So we work very closely with them. A lot of the individuals that we are seeing or trying to find have also crossed bases with the folks at West Virginia Health Right. So it's been a very lucrative, I think, experience to be able to kind of, have that connection or communication ongoing between us and them, since we are working with a lot of the same folks. Mm-hmm. But it all comes down to housing and addiction. And that's really what our linkage and social workers are really trying to work on. HIV oftentimes comes its way on the bottom priority list for a lot of people. It's our number one priority, but really in the grand scheme of things, it's housing and addiction services. And then more recently, we've been trying to do more mobile services, because we found that for many in the cluster, coming to a large, our clinic setting is in a large hospital system, which is intimidating and large, and even it's just me personally, I sometimes find it intimidating to navigate that system. So for our group of folks, that's a kind of been a barrier. Also, many of the folks in that group have had maybe prior experiences within the CMC system that weren't always the greatest. And so it's been a real challenge getting people to actually come to a regular traditional clinic appointment. So again, we're trying to meet people where they are, and especially for initial contact, to be able to go out and see a provider in a more mobile location to develop that relationship and establish the trust, and then get them back into the clinic. We were able to start that 2.5 weeks ago, and we were able to successfully engage 5 people just in 2 weeks that we had not had any contact with at all. So I think that I'm optimistic that will continue to come, to fruition and be a more effective strategy to engage people. Right. But that's kind of it in a nutshell.
Perfect. Thanks. I'm gonna come back to you. And if you haven't done these before, or been on one of these before, I kind of just like randomly ask random questions that you're like, I'm so not prepared to answer that question today. And no, you can't have my social security number on a Zoom, but it'll be something along those lines of whether or not I can have your social security number or credit card information that I might use to buy things for myself later. Okay, cool. Okay. All right, cool. As long as you're cool with it. So Angie, so that's a large hospital system that's working. You are a free clinic, is that right? You're not a FQHC, you're a free clinic. I think that's one of the things that people need to be able to understand. What's the difference between a FQAC and a free clinic?
Right.
And what are the, you say price?
No, I said right. I'm agreeing. Right.
Okay. Okay.
But price, yes, that's true. So free and charitable clinics are just that, free and charitable. We see the uninsured patients totally free of charge. There's no sliding scale at all. We don't charge for any services. There's no copays even. We see our clinic sees Medicaid and Medicare. Everybody has to be under 250% federal poverty level. Again, we've got stuff written by legal people. We don't do copays on any of that. The medications we do here through a lot of drug programs. So we keep that curtailed to the uninsured population. It just makes things a lot easier in terms of gatekeeping. And then people with Medicaid or Medicare, we have their medications prescribed to a pharmacy of their choice. Now, somebody's here and they need an antibiotic, or somebody needs PrEP, somebody needs something, Vivitrol, and we have it, and it's something we bought, we're going to give it to them regardless. We want to make sure they get their meds. So huge difference is reimbursement plays zero, nil, none into anything that we do here. We don't worry about anything getting reimbursed. We do what we can. We bill for it. We package as much care as we can. We'll take it on the road. We don't care if we get paid for it. That's why we write a lot of grants to keep our budget alive and keep us where we need to be. But that's one thing, prior to Obamacare, we were strictly seeing uninsured. And when we merged over, the board was really adamant. We were adamant that we didn't want to lose that mission. So we are sandwiched between two FQHCs here in the Kanawha Valley, and we still have over 40,000 patients. So there's still a huge need.
Right. So one of the ways in which we have all come together is particularly around COVID, right? CEG got some money around COVID vaccination and influenza vaccination. So I want to talk a bit about kind of how important this influenza vaccination is going to be, not just for the work we're going to be doing together, but what do you think the role of the flu is going to be in this upcoming season, given that so many of the folks that the folks that we are kind of working with are homeless, marginally housed, and may or may not be coming in for flu vaccination. And, given that folks were kind of in the house for the last 18 months, but everybody's out now and not wearing a mask, and some of these folks aren't vaccinated, what's our plan, Stan, to get folks vaccinated for the flu? I'll start with you, Angie, since you went to the land of nod. You're over there.
Yeah. So last year there was a big talk, a lot of CDC about the twindemic, about COVID and the flu, and they were kind of gearing up for it, and it really didn't happen. Retrospectively, a lot of people are saying it's because, so many people had on masks. People were really serious about quarantining. There was a lot of fear. We didn't have a vaccine for COVID. I really am worried about that. It's very scary. I think about the population that we serve, especially the homeless and the shelter population. Just watching people, that I know and love, and our patients that have contracted COVID, how sick they are, and to imagine influenza on top of that, both in their own right. They're killers together. It's a very uphill battle. So I think it's so important that we get that message out there, and we really need to get people vaccinated. We're trying as many, if we have a COVID vaccine or a flu vaccine, there goes I should turn my phone down. We need to make sure we're offering both. We don't do one without the other. It's a great thing now that originally COVID vaccine, you had to get it by itself. You had to wait so many weeks, and now you can get them both together. So I think we're not doing our due diligence if we're not offering influenza vaccine along with COVID. It's really important.
Okay, cool. Dr. Teague?
I would just echo what Angie said. A lot of the homeless population, at least my people that are HIV infected, so many of them have underlying other serious comorbidities like past endocarditis and valve replacements and prior lengthy hospitalizations with sepsis and other infectious complications, they're going to be really set up to get really, really sick with either COVID or influenza. And, you know, we try, I'm sure we all do, you know, every encounter that we have to really try to endorse both vaccines with the population. What's interesting is that sort of that vaccine reluctance that you see in the general population is pretty similar in the homeless group. About a third of them tend to be really resistant and are, you know, sort of victim to the same misinformation campaigns that a lot of the general public has been subjected to. So everything that we can do to continue that educational message and trying to relay how important it is for them, that if they get this, it could really wipe them out to a greater extent than what has been seen in the general population. So it is critically important.
Right. And so we've just been joined by Suzanne. Thanks for being able to join us. I know you jumped off of another meeting to come join us. Can you tell us, they don't know you, so could you tell us a bit about who you are and what you do so the good party people on this call can know who you are and how you spend the funness of your day?
Sure. Thanks, Tony. And I apologize for being a little bit late. I'm Suzanne Messenger, and I'm the State Long-Term Care Ombudsman in West Virginia. That's quite a mouthful. The word ombudsman just means citizen representative, and the citizens that I represent are people who live in our long-term care settings, like nursing homes or assisted living settings. I work for the Bureau of Senior Services, and the Bureau of Senior Services has a contract with Legal Aid of West Virginia. Legal Aid has 3 different programs, actually. Obviously, the legal program. They operate our long-term care ombudsman program. And then they also have a behavioral health advocacy project to support people who are living with behavioral health issues. So as an ombudsman, my job is to kind of coordinate when somebody who's living in a long-term care residence, if they have a concern or a complaint about their care, they can call us. If a family member has a concern or a complaint about their care, and surprisingly, if a staff member has a concern or a complaint about a resident's care, we're going to talk to the resident as best we can and try to figure out what's going on and to try to work with the resident and empower them to figure out a solution to help them get the best quality of care and the best quality of life that they can. So that's what we do as ombudsman. I also chair a statewide task force called the Financial Exploitation Task Force. And that really is to provide information and education to folks about the problem of financial exploitation, particularly of seniors, but also really any vulnerable adult here in West Virginia.
Suzanne, I'm sorry to interrupt. What's financial exploitation? Does that mean I borrowed $20 from Amanda and Amanda says, I'm not paying you your money back? Can I call you to get my $20 out of Amanda?
Well, no. I wish I could help. Financial exploitation is a crime. And it's the use of somebody else's money. And I'm really putting this really simply, the use of somebody else's money without their permission. That might be money in a bank account. It might be, I might even have a power of attorney document, a legal document that says I can do some things. But if I'm doing something wrong with that power of attorney document, more than what the person who gave me that authority intended, that could be financial exploitation.
Okay.
You're welcome. So the members of our task force include Adult Protective Services. We have some members of the bank industry. Legal Aid of West Virginia has a financial exploitation unit. There's a person who runs the Medicare Patrol, the Senior Medicare Patrol, which deals with Medicare fraud. Medicaid fraud participates. Some folks from the U.S. Attorney's Office. So it's really a broad group, AAP, trying to figure out what's going on and to try to help our folks to educate them, one, about what financial exploitation is, to watch out for it, And then if there's a problem, we can point them in the right direction. The task force doesn't actually do the investigation.
Okay. So let me ask you this. You said you also, you do something with the congregate living facilities. Those are like what we would call senior citizen homes, right?
Mhm.
Right. So for
Correct.
all people, how many of those are in the state?
There are 124 licensed nursing homes in West Virginia right now.
And are all of them free, or are they private pay? I mean, how do you end up there? I mean, and how many are in the state for the state? How many are like, I can go for free? How many are I got to pay? How?
Sure. Well, unfortunately, we don't have any that are free. You have to pay in one form or another. And for our nursing homes, the most common way that people pay for their care is through the state's Medicaid program. And nursing home Medicaid is quite a complicated duck. And if you really want me to talk about that, I hope you have 3 hours. But basically, nursing home Medicaid is really only intended for people who are poor. And there are a couple ways to be poor. One, you can be poor by luck, or you can be poor by design. So people will work with an attorney to make themselves legally poor enough in order to qualify. And generally that means you have to have less than $2,000 worth of assets. But in order to qualify for Medicaid to pay for your care, in addition to being poor, you also have to be sick. And the state has a definition of what is sick. There's a tool that they use called a PASS 2000. You have to have 5 deficits on that PASS 2000 that the state says. And so if you're poor enough and sick enough, Medicaid will pay for nursing facility care. And that sick component is really important for folks to keep in mind, because a lot of times people will have Alzheimer's or dementia or pretty serious memory problems.
Right.
And folks think, well, they should go into a nursing home if they're not sick enough. And that means that they need physical hands-on help with things like eating and dressing and bathing and grooming and walking and wheeling. If the person's pretty physically fit, they're probably not going to qualify for nursing home Medicaid. And some people are surprised about that. Even if Medicaid does pay, that doesn't mean that I don't have to pay anything.
Right.
Typically what happens is I have to pay almost all of my monthly income, however much that is, to the nursing facility as my share of the cost of my care. And then Medicaid basically pays the difference.
Man, that's, I mean, so that takes a lot of prior planning though, I think, right?
It can, although there's a surprising number of people who wake up one morning and find that's the world they're in.
Right.
For our assisted living, those provide a little lower level of care. And in West Virginia, none of our assisted living take Medicaid.
What?
None. So that means that's all, pick up your pocketbook and open it up and pay privately. That's how assisted living for the most part in West Virginia.
We don't know each other well, but I don't have a pocketbook.
Well, for people who don't have a pocketbook or another holder for their wallet, assisted living in West Virginia is not accessible for them. And so that's a real gap in our continuum of care.
Huh. So, you know, I know you and I had this conversation a bit before, and one of the people that's on this call today is Trina Scott, who's with Gilead Sciences. And so I know she's like, why did you bring my name and why is my name in your mouth? But one of the things that I want to talk to you about, Angie about, and Dr. Teague about is that the need to kind of educate our seniors around HIV, STDs, STIs, and so I mean, because I think because you said there's over 100 facilities in the state, and I'm like, is there any sort of comprehensive plan that would educate them, like any sort of in-service to educate seniors about STIs, HIV, and other things? Because I think people don't know the seniors are, you know, this is not your grandma seniors. People getting busy in these nursing homes. They're having a good time. And Jello might be used for a multitude of purposes, is all I can say. And that's all I'm gonna say about that. See, Suzanne's laughing. She's like, she know there's Jello night at the nursing home and y'all just don't know what y'all think it means something else. So tell us a little bit about are you seeing anything along those lines around the need for that and impact of HIV, Hep C during COVID, because people were more on lockdown. They were locked down just like us, but they, you know, they had potential partners in there.
Absolutely, Tony. People have the misconception about nursing homes and assisted living that those are places that you go to die. A lot of living that goes on there. And a lot of the things that we do in life happen in the nursing home. And whether that's being intimate with somebody or even bringing your history with you that happened before you came into a long-term care facility. It doesn't mean it actually has to occur in a long-term care facility. Intimacy and sex and long-term care, those are still kind of taboo conversations. Nobody really wants to talk about that, but it does happen. And as far as I know, Tony, there is no coordinated effort to really provide education to people about STIs that may have occurred before they came into a long-term care facility or that they may acquire after they come into a long-term care facility.
Angie, Christine, Dr. Teague, do you guys have any kind of senior education program, or do y'all do an outreach effort to seniors, or do you see a number of seniors coming in looking for screening or being impacted in this way?
Well, I can just say from my experience, we did have an individual that was diagnosed in a nursing home. This has been probably five plus years ago, but she was over 75 years of age, newly diagnosed HIV. That was fairly unusual. And I know that we're talking a lot about testing today, but I will say that nationally, 50% of the HIV population now in the United States is over the age of 50. And we were seeing that in our clinic. We have two distinct populations. We have people that have been with us for years and years and years and are now 50 plus. And then sort of this newer group, the 20 to 40-year-old population that is substance use disorder group. But I would just put a plug in that even for people that, you know, I think nursing homes need to be aware that that there is more HIV in the older population to begin with, as our people continue to age, given the normal longevity with potent antiretroviral therapy now, that they probably will be seeing more geriatric type patients coming into their facilities, and just need to be aware of that. And certainly if they are sexually active, hopefully that they're on antiretroviral therapy that would prevent them from transmitting to other people sexually. But I think it is, you know, something to keep in the back of your mind. And I know a lot of our education curriculum for providers now is surrounding geriatric medicine topics, to address cancer screenings and prostate exams and bone loss and frailty and all those things that unfortunately go along with aging, that are a critical part of what we do now in the clinic.
Perfect. Angie?
Specific outreach, but that's a good idea. We should probably set that up. But it is part of a comprehensive care. You know, we see adults, you know, we see people, you know, we see kids for family planning, but like 18 and up all the way through till death, we see adults. So we are seeing more of that. We've seen STDs in that group. You know, a lot of people, as I get older, thinking, oh yeah, life does not stop at 50, and now I'm 50. So, you know, people are still getting friskier when they're older, and we need to be cognizant of that, and, you know, educate people more. So we do it, but I think we could do a better job of it, actually.
Right. Trina, I know you had a couple of notes there, and I didn't get to you right away. if you don't mind, if you could grace us with your presence again, I would appreciate it. I mean, if you don't mind taking a few moments out of your busy day to share with us some of the things that you do and some of the things Gilead Sciences is doing, because I know you have that, Gilead has that HIV and aging program, and I think that really, Suzanne, you really should apply with Gilead for that HIV and aging program to do an in-service for that 100-something or a smaller cohort of those clinics. I said it out loud and it's in a recorded venue. So now Trina has to actually probably maybe call somebody and tell somebody that I said that. But all right, go ahead, Trina.
So I'm not a part of that division, so thank you, Tony. I am the community liaison in the HIV business unit. And yes, I am able to provide so many resources to the community because I cover all of West Virginia and Maryland. So we have population-specific decks, we have care continuum decks, we have prevention decks, and I know we just had National HIV and Aging Awareness Day, and there's so much that we could be doing in our community. And I'll list some of those resources down at the bottom. And also, I think as we are moving forward to really educate providers across the care continuum on prevention and treatment efforts, we're able to host programs, whether it's dinner, lunch, or breakfast, to be able to educate everyone who is here today on some of the updated and upcoming tools that we'll be able to provide. And then also we have resources like tangible resources, brochures and booklets and pill bottles and pill charts and bags and all of those resources that community members tend to appreciate when we are out in the community. So I would love, to make sure that when we're doing those outreach efforts, Dr. Teague and Dr. Settle, that you all have me as a resource for some literature and some, I call them tangible items. And then also let's just talk about sponsorship opportunities. We should be doing more in the community to leverage the dollars of Gilead Sciences. So thank you.
All right. And that's maybe Suzanne, maybe that's a place where we could all start together. Maybe we could do some kind of joint events, and we take on a group of those. But I was having a conversation with somebody in another division that Trina is not in, actually about you, and specifically about you, and that there are over 100 facilities where I just think that the basic HIV information for seniors is needed and would be of value. And I think, you can do it yourself, or we can do it. We're happy here to help you, I think. And I think that's what kind of these calls are about, is that, we're all super busy, but we also all have a little piece of something that we can do to help the other one. And I think that's what, I don't see us getting through COVID. I don't see us getting through HIV. I don't see us getting through it another way unless we work together and work collaboratively. The other thing I really want to talk about is I want to talk, because I know we have like 20 minutes left, and I'm going to open it up for some questions in a second, is two things. One is, Trina, you might want to have to jump back on here for a second, or did she leave? But I want to talk about where we are with PrEP and whether or not you, Angie, and Dr. Settle and Dr. Teague are talking about PrEP. What are you doing about PrEP, particularly with the new technologies that are coming on board? Are you seeing a request for PrEP in your facilities? Should we be doing more to educate people about PrEP on the provider level and on the consumer level? And then Suzanne, for you, are seniors even talking about PrEP? Are they looking for PrEP? Do they know about PrEP? Should we be talking to them about PrEP? And so I'll start with Dr. Teague and PrEP.
Tony, before you do that, as someone who is relatively new to this conversation, what the heck is PrEP?
Now, see, and there we have it. That's very important answer. It's pre-exposure prophylaxis. There's a PrEP, and then there's PEP, which is post-exposure. So what we are able to do now is that we can have treatment that is available to us as individuals who are sexually active, that if we take these medications before a sexual encounter consistently and often, that we can take medication, and often it's a similar medication that treats HIV, but what it'll do is that you're 99.9% not likely to have HIV transmitted. So they call it PrEP, pre-exposure prophylaxis. So PrEP or PEP. PEP is the post-exposure prophylaxis. So I think that one of the things that we're trying to do is, particularly in West Virginia, given the rising case numbers, I think that the fact that we don't have a strong PrEP program for people who use drugs is a challenge. But because I think it's a very important opportunity to get folks to prevent HIV. We don't have a PrEP equivalent for hepatitis, but we do know that we can do prevention efforts for people who are seniors, people with lived experience, that we can prevent HIV. There's behavioral opportunities for us to do that with talking to people, getting people tested, and that sort of thing. But then there's also a biomedical response, and that's what PrEP is. So now I guess we know what we're going to go to the senior homes and talk about, and HIV prevention and PrEP. So who's writing the proposal? Angie, you already got 60 proposals in grants anyway. Maybe just make it 61.
Yeah, but like way more than I do. So I think it's.
Excuse me?
I'm just kidding.
You're on mute. You keep going in and out. You keep going in and out.
I'm sorry. Can you hear me now?
Yeah.
Okay. So this is a huge need. We're doing a pretty good job at that. I think Rhonda, I just texted Rhonda and said I lost my numbers. Wait a minute. We have 62 people that we've started on PrEP. And that's big because PrEP is not used enough around here. So, and that's just since we kicked off our West Side branch in June. It's highly underutilized. Not enough people know about it. I personally think it should be in the water. Almost everybody's at risk some way, shape, or fashion. And I think that we need to do a better job about that. I mean, if you're at risk sexually, if you're at risk, through IV drug use or whatever, if, you're a sex worker, you don't always know what your sexual partner's doing. You may be at risk and you don't know it. You may think you're in a monogamous relationship and you're not. I just feel like we need to do a better job about PrEP. I'd like to see more billboards. Better job.
All right. Dr. Teague?
So we, for many years, we have been advocating pre-exposure prophylaxis in the Ron White program. One of our disadvantages is that we are not able to use Ron White funding for PrEP specifically. We can't use our funding for medication or for provider visits or lab visits for PrEP, but we can talk about it and we can educate people and navigate. But as Angie has said, it's woefully underutilized in West Virginia. And I think part of that is, it's marketing. Historically, West Virginia has been a low incidence prevalence state for HIV. And so there's not been a lot of finances dropped into West Virginia to talk about PrEP and to engage providers as well as the general population and what it is and what it means. So people still, you talk to providers, you talk to patients, they have no idea what it is. Or if you're working with the injecting drug use population, they believe, and rightfully so, given how it's marketed, is that it is an STI prevention method, which it is. But I think there's a lot of misconceptions amongst the population on what actual groups it's beneficial for. And now that there's additional funding for PrEP medications through expanded access programs and government, the ending the HIV epidemic programs, and with the new U.S. Public Health Task Force Grade A recommendation for PrEP, copays should be going away for the cost of provider visits and labs. So financially speaking, it should be easier for people to obtain PrEP now. We just have to continue to work through the barriers of demystifying PrEP and how it's to be taken. And I frankly am very, very excited about the new injectables that are coming. Right now, what we have are oral dosage forms that really should be taken every day or most every day of the week. And for many groups, that's difficult. There is what's called on-demand PrEP that has been licensed more in other countries besides the United States, but you can take it in anticipation of sex. So, fewer days around potential exposures. But in the United States, we really do it, dosing daily. But the newer injectables, there is a monthly version that's coming out, hopefully by the beginning of next year. That will be an IM injection that patients will have to see a provider for. But I think for some groups, this is going to be hugely beneficial. And then that even further down the road, there is another injectable that's a sub-Q injection every 6 months. So there are going to be other alternatives in the future, implantables perhaps. So for many groups, I think that, this is going to become easier, but we still as providers need to do a better job at educating our own community, our other peers in the medical community, but also our patients.
Right. Because like one of the things that I think is, I think that the subdermal, like which is like for those of you that have experience in reproductive health, would function a lot like Norplant or something like that. I think I think it's a game changer, particularly for people who are marginally housed, people who have injection drug use histories or drug use histories, but also, again, I have some sort of housing issue, which I think, which requires a person to just not necessarily have showing up at a doctor's office either once a month or once every 6 months as the number one priority.
It will be a game changer, in my opinion.
Yeah, I agree. I think it's a game changer. Angie, you had the end up.
I was just going to address this question in the chat. So part of what has enabled us to do the 60 or so is the mobile medical street medicine unit, because it's equipped with a lab. A lot of the barriers are that when you reach out, and do street medicine, not having the lab work there. So a lot of times you have to do these precursor labs, which Christine will tell you about, to check people for, their kidney renal function and liver function. So with this, we are now able to do that right then and there. So that's why we've been able to do this. And actually, out of the 62, believe it or not, we've only had 5 that didn't fall up for their 3-month lab so far. And of those, 32 admit to using drugs, so at least a little over 50%. So that's pretty phenomenal in that population. And I think probably the key is, taking it where they are, in the streets and then doing follow-up there. But I agree. It'd be great to do the 6-month, all the injectables. I'm just praying. We'll need Tony's help, because when that stuff comes out, a lot of time, let me finish now. So like these things are on patent, or you can't get them, or you can't get this one, you can't get it through a program. You can only get the cheaper version. We need people to understand that our patients are worth it and they deserve the best. So when these new formulations come out, this needs to be a priority, a public health priority, so that all of our patients that suffer from SUD and that need PrEP can get it.
Yeah, I will echo that, because there is an injectable regimen that has been approved, a 2-drug regimen, injectable regimen for treatment of HIV that has been approved for several months now. But I have spoken to other colleagues across the country that have had real difficulty in getting it, jumping through all the hoops with prior auth and things of that sort. So
is this the ViiV one or the
cabotegravir rilpivirine combination? Right. So we have to do a better, I think we will have to have a plan and to demonstrate what is the cost benefit ratio of an injectable PrEP regimen. What does one infection cost, given how many potentially you could prevent? And I agree. We've got to make sure that it's going to be available to the population. Otherwise, it's not going to benefit us at all.
Let me ask you, you both, and all 3 of you, another question, but probably more so for Dr. Saddle and Dr. Teague. Because one of the things that we're doing at CEG now is Dr. Ware, and I don't know if Dr. Ware is here, but we're creating this, what we're calling a syndemic research lab. And one of the things we're looking at is where clinical trials are and where clinical trials aren't. Do you, either of your locations have ongoing clinical trials, A? And then B, are clinical trials something that you would want to be a part of if you're not? Uh-oh, Angie, you're not talking. Your lips are moving, but it's not coming out.
You hear me now? Okay, sorry. So I'm very protective of our population. If I saw something that came across that I thought was some kind of winner and really would make, you know, great strides. But honestly, and I think Rhonda will agree, historically, people see our population, I don't like them to be seen as guinea pigs. I think people try to take advantage or think, you know, because it's a free and charitable clinic that somehow that they would be more susceptible to coercion or whatever. So I'm very protective. It may be a little hard to approach on these issues because it would really have to be something that I really think would be worthwhile, because I'm very protective of our population. Something like this, I would do it because if it's a proven drug, but a lot of times we've been approached with all these wild ideas people want to try, and it's like I'm just to be honest, they wouldn't try it in a regular doctor's office where people are, you know, insured and paying or whatever, and so they would try it on our population, and so I'm very careful.
So that's okay. So that's part of what we want to do, right? So part of what we want to do and what we think is needed is both education of the providers, right? Like, okay, here's what clinical trial, here's what an ethical clinical trial is and what one isn't. And, right. and putting you in the position of picking and choosing which ones, but also being able to do that level of education for the individual consumer who's likely to participate in the trial. Like, here's what a clinical, before they're asked to be in the trial, how do you become a good trial participant?
Right.
A good trial participant. But I think we have to do it for both the provider and the individual consumer.
Because a lot of times they try to, you know, tie in like, you know, money. And it's not really good at this point because they're, you know, they're disenfranchised and they're at risk and they're in a vulnerable state. So I don't really like, you know, that to be part of the equation.
Well, that's what I say. I think incentives work, but I think that if the incentive is coercive, then it doesn't work. If my incentive, you know, and so I think that we have to be very conscious and cognizant of who and what and how we offer incentives and at what level do we offer incentives. Dr. Teague, I apologize.
Oh, no, that's okay. Here at CMC, under the CMC Health System umbrella, we do have, it's been rebranded as the Institute for Academic Medicine, but there is an Office of Grants and Development and Compliance and a Clinical Trial Center. So we have the benefit of having a local investigative review board. So every clinical trial that we have access to goes through a large group, is heavily scrutinized for things that you mentioned to make sure that vulnerable populations are not misappropriated, and HIV is kind of a protected class of individuals, so they get extra special consideration. As far as access goes, we can do our own sort of investigator initiated protocols here, and many do research with grants from other drug companies and other foundation with other foundation support. But the actual, I guess the clinical trials that are most known, or the clinical trials of newer agents under development, you go through the AIDS Clinical Trials Group. And there are many different academic medical centers throughout the country that are registered as ACTGs, and unfortunately we're not. If we have a need to refer, it's usually UPMC or Ohio State are the two centers that we have used in the past for, usually they were for medications that were further in development for multi-drug resistant patients, but certainly if there are prep trials for investigational drugs, I think that we would be interested.
All right. So we are kind of down to the last few minutes. And one of the things that I wanted to kind of do is, first of all, say thank you to everybody that came today and that joined us today. I think we learned a lot. I mean, I certainly learned a lot. No, I don't know if you learned anything, but I certainly did. And then Caroline, I know you're here. Caroline, can you remind me later to do an email for Suzanne to our contacts at Gilead, and particularly Trina, about really actually finding some money for that HIV and aging program, that we would talk about PrEP, aging, and other prevention. And I think, I really do think we should do it as some sort of joint effort there. But we will, Suzanne, we're going to get you some money to go educate in these facilities. Don't worry, Angie's got like 750,000 grants. So she can just shake out her sofa cushions and it'll be enough money for us all to live. Trust
Yeah, 750,001.
750,001. The other thing is that next month on this call, one of the things we're going to be talking about, we're going to be launching, is our Appalachia Partnership Fund, which both Angie Settle and Dr. Teague are a part of in different ways. But we'll be talking about that. And we'll also be talking about the grants program, the grant application process that we're going to be launching. We're going to be putting $1 million back out on the street to be able to get individuals, organizations, and institutions to both vaccinate and test for COVID and the flu, HIV, viral hepatitis, and substance use disorder. Those are the resources that we were able to receive from the Centers for Disease Control. We hope to be able to talk about the project that we will be launching, and I'm always going to forget it wrong. So Amanda, be ready to jump in and save me. Webster, Nicholas, Braxton, Upshur, all four of those counties, where we'll be doing some outreach on HIV, Hep C, COVID, influenza testing. But one of the other things we're going to be doing in that region that we got some support for is training and evaluation and testing on diversity, equity, and inclusion. And what we'll do next time is also probably talk about the other project that we're working on, which is what I'm calling the Appalachia Star Project, subtitled We Are Appalachia, which is really looking at Appalachia culture and heritage and how it's a barrier and facilitator to us with economic issues, health issues, environmental issues. So we want to get a cultural heritage designation for Appalachia. That's what Lee and Dr. Chaddock are working on here at CEG. And somebody just sent me a note. For more information on the Appalachia Partner Front, we will be hosting a webinar on Thursday. That's what Amanda just put in the chat. And I read it verbatim. I didn't want to wing it. That wasn't a good time to wing it. So if you want to join us on Thursday, feel free. We'll probably send out another email between now and then. It is now 3:01. I apologize for starting late, but we have another meeting with Dr. Hodder. And I want to thank you all. I want to thank you for being my friends, my colleagues, and dare I say, my West Virginia warriors. Because not just mountaineers, but I mean, this is a fight. We're in a fight for a lot of people's lives, and we got to do this together. And that's the only way this is going to get done. Thank you, Stan. Thank you, Angie. Thank you, Christine. Everybody have an amazing week, and I look forward to talking to you soon or seeing you on Thursday. Ciao, ciao.
Thank you.
Bye, thanks.